lecture about his career and what he's done, which will be really useful. So the next symposia is about challenging knee injuries. And we're going to discuss quite a few different topics, but I'm going to let the stage, lend the stage to Roland Tomé, who's going to kick things off.
Thank you, Eric. How do I start this? It was not this topic. It was the wrong one. Susan? This one. Huh? This is the one. Sorry. This is the right one. Yeah, structural diagnosis. That means if we have a ligament injury, or if we have a tendon injury, or if we have a cartilage injury, should we let that decide upon rehabilitation? Or is there another way to look at it? Of course, it's important with the structures, but maybe we can look at it in a different way. This is a general schedule on how an injury appears for us. You have some injury. It could be acute, it could be an overuse injury. It usually starts up with an inflammation, and that's the body's reaction to tissue injury. But the inflammation part in general is very short, a couple of days. Then the body thinks, we have to repair this. If you cut yourself in the hand, the body thinks we have to repair it. But the body repairs injuries with secondary tissue. It's not the prime tissue. For tendons, it's a collagen type 3, I think, and the super tendon has collagen type 1. So in the repair phase, you get a repair here, and you see it. It's a scar. So, and the repair phase takes a couple of weeks, depending on how large the repair has to be. And then the body starts to remodel that scar. So just like in the hand, suddenly the scar is gone, and it's prime skin again. Same with the tendon, muscle, bone, and so on. Maybe not the cartilage. That's tougher. So, and a lot of research the last 20, 30 years indicate or have shown that these phases, the repair phase and the remodeling and maturity, goes faster and ends up in a better end result if you exercise at the same time, if you're being active, if you're mobilized. That's why we don't put injuries in a cast anymore, no mitella for shoulder injuries, and so on. Early mobilization is the key word, because this will be a better repair and a quicker remodeling of the injury. But if you go on too fast, if you have your scar here and you're there scratching in it, or you run again and you get a small tear again in your tendon, muscle, or whatever, you're going to prolong the repair phase, and the scar is going to get bigger, because some scars doesn't disappear. I bet you have scars on the body that doesn't disappear. It's not perfectly remodeled. The body can't remodel everything. So everybody is okay with that? And then you know, if you have an isolated muscle injury, the body has tremendous capacity to heal that. The repair and the remodeling can be done in a couple of weeks, 1 or 2 months, and the injury is back in play. But if you have a muscle injury with a small tendon injury, you can say in general you have to prolong the time twice as long, 3 times, 5 times as long, depending on the size of the tendon injury. So the tendon and ligament, they take longer time to repair and remodel. But do you know if you have an isolated muscle injury or if you have a small tendon injury also? It's very difficult to know when you see the patient. And if you twist your knee, do you have a cartilage injury as well? Or is it only an isolated ligament injury, which is so rare that it's probably not existing? We saw a figure of 12% was isolated, but it depends on if you can you see all the potential injuries in the cartilage? It sounds like if you twist your knee, you always get a cartilage injury. Small one, but I think they're there. We'll see what Mats has to say about that. But we know the cartilage is tougher, takes longer time. But it follows the same principle. There is some repair, not very good, and the remodeling and so on. But if you take your time, it will come, and the potential is great. But of course, a small injury goes a little faster. A larger injury takes more time, but it follows the basic principles. So we have to realize that tissue healing, restoring tissue strength and function, it takes time, but it has a great potential. So when the patient says, I have a muscle injury and it's gone 3 months now, then you realize maybe you didn't have an isolated muscle injury, there were some tendons involved. So no problem, just keep on the rehab, the potential is great. And you've met stubborn patient that goes on month and month with really severe injuries, and they get well. So instead of looking at the all injuries are different. That's why I have this picture. All injuries are different, and the healing takes different time. So how should we monitor this? This is what do you call it? Skavsår. What's that in English called?
Blister.
A blister type. Walking in tight shoes. And if you do overuse injuries in the shoulder, or in the Achilles tendon, or in the knee, you can say you have a blister, or a skavsår. And if it looks like this, it's going to go away fairly quick. If it looks like that, it's going to take a little longer, right? So if you have a bigger injury look like that, it's going to take maybe 2 weeks, 2 years. So too much stress in relation to tissue tolerance, that causes our injuries. But all injuries, individuals, sports, are different. And that's what we have to take into consideration. So what should guide our rehab? It shouldn't be the structure. It should be more of what symptoms, functions, strength, endurance, and motor control does the patient show you. And you can make a list of 10 things that are potential weaknesses, and you start to work with that. And some of the weaknesses goes away quick, some stay longer, no matter what tissue, no matter what structure. You don't really have to know what structure is injured. And in the knee, you don't know exactly which structure are injured. You know it's an ACL injury, but as we said, there are other structures in the knee that are injured, and so patients present different symptoms. So if we have this picture in mind, we don't have to face down too much on the structure. Patients can come back and say, oh, I have a tendon injury. So, and say, it's never going to heal. And that's devastating. Don't look at the structure. There are many tendons that can heal if you take your time. If you have a large injury, it take a longer time. So I'll stop there, and we ask the next one to come up. Is that Christian? And we're going to see what's going on with the Osgood-Schlatter disease. Thank you.
Thanks. Okay, so the next talks that I'm going to do will be the work of Michael Ratliff. And Michael is a very, very good researcher from Denmark. And this was part of his postdoc, where he actually got quite a lot of money to look at 10 to 14-year-olds with knee problems, with knee pain. And I was sort of mentoring that project. So please be careful, don't tweet any of these slides, because this is unpublished data. It's submitted, but don't tweet any. You can tweet some of it, but don't tweet any results, okay? So the first study I will present on is this cohort of 252 adolescents where 200 of them had knee pain. And the idea was to look at these young people with knee pain, unspecific knee pain, and we wanted to compare their pain patterns, especially their physical activity and their knee function in relation to both PFP and Osgood-Schlatter. I'll tell you a little bit more about why that was relevant. So this is a study that Michael did, a very good RCT published in BJSM, where he looked at patient education and compared it with patient education plus exercises. And these patients were 15 to 19 years old. This is published, so you can tweet this if you want to. Michael will be happy. And this is what the study showed, or when you look in the literature, was that Michael could actually show that if you add exercise to education, you would have a better result if you just do education alone. The problem was that the difference between the groups were not that big. A lot of people didn't recover, and it also, from Mike's impression, was that one of the reasons for that was that a lot of them kept on being physical active during the treatment. The other thing he found was that he thought that he wanted to get them as early as possible, and so he started from 15 to 19 years old was in this study. And what Michael actually found was, when he then asked them how long have they had their symptoms for, many of them had for 3 or 4 years already at that time. So the idea with the new study that I'm going to present now is actually to see, can we even come closer to the debut of these symptoms? So instead of being 4 years, 5 years down the road and having to try to fix something, can we get earlier to when they actually develop this problem? Some of the data here from his RCT, and you can see how many months that they had these issues when he saw them here. So the first part of this is a cross-sectional study, just to try to get an idea of some of the more descriptive data on pain and also on physical activity and also on muscle strength. And what we did was we started off with a PFP trial or patient study, and then when we included patients for that, we kept getting patients with Osgood-Schlatter. And in the end we decided, okay, why not look at them at the same time, because apparently there's quite a lot of them as well who would seek in to be part of the trial. And then we also recruited a control group, matched for age and gender, and looked at that. So this is what you can see. So you have 3 groups here. You have the patellofemoral youngsters here, and then you have the Osgood-Schlatter, and then you have the pain-free controls. And this is probably what you would see as well. Majority is female in the patellofemoral group, whereas the Osgood-Schlatter is more 50-50. And so we tried to match for that. The other interesting thing, I think, is you can see how many are actually taking pain medication at some point. 24% of these young kids are taking pain medication when they have PFP, while if you have Osgood-Schlatter, that is less. You can see that their cool scores, you know a little bit about this score now, are very, very low on pain and sport. And you can also see that the worst pain they have is quite high on a normal VAS scale. Worst pain average pain. Again, still some of them, on average, still more than 2 years. And then one of the things we were interested in was sports participation. So all of them participated before, more or less. And then the question was, did you actually reduce your sports participation because of your knee pain? And you can see here that a lot did in the PFP group, but that also a lot didn't. And again, from the OSD group, you can see that half of them reduced the sport, which means that half of them just keep going. And this was exactly what Michael thought that he was seeing in some of the other studies he did. So here is the physical activity, and this was monitored in 1 week after the first visit, and he had active graph, which will objectively measure that. And you can see what was really interesting was that they have the vigorous activity, almost 2 hours of that across all groups. And there was no statistically significant differences here. And you can also see, so this group who are in quite a lot of pain, they have a lot of activity in general, and a lot of activity at vigorous level. We don't know how much load there was in this activity. Could be vigorous swimming or vigorous cycling that might have less load, but a lot of this would be also just running around in the schoolyard, maybe just playing some football, basketball for fun, and then maybe they go to their sport as well. So this was exactly what Michael thought was going on, and you can see that most of them would definitely reach the minimum PA per day. These are the strength data across, and this is just knee extension. I have other data I will show you. And when you target these with exercises, we usually give them exercises for the hip abductors, knee extensors, and maybe external rotators. That would be quite normal. The thing is, when you look at these young individuals, the knee extension is usually not that big a problem, and you can see that maybe the girls have a little bit of an issue. I think this was statistically significant. But for the PFP, there's no difference in their knee extensor strength related to compared to the controls. So we have to be careful just because maybe older people, not old, but other groups benefit from this kind of exercise. This group doesn't have that deficit. What we also saw, and this was something that we've seen clinically for many years, is that when you look at the OSD group, they actually also often, they show up with quite a big deficit, and they almost have 30% deficit in the knee extensors. And that was a very similar pattern in both groups. Here you have the hip abduction, and you can say might be a little bit, again, in the girls' OSD, but other than that, we didn't see a lot of difference in abduction. So again, might not be the most important thing to intervene on in this age group. Then we have hip extension, again, very, very similar to controls. So the take-homes from the first study was that these kids have quite a lot of pain, and they have quite a lot of reduced sports function, and some of them even take painkillers, and they don't seem to change their pattern just because they have pain. So their physical activity pattern is really, really high still, on average. So that was the first part. Can you change the other one, Susanne? So this was to get an overview of what we would do with these patients and give us some ideas to how we could actually intervene. The thing is with osgood-Schlatter, yes please. The thing is with osgood-Schlatter, there's actually almost no studies on it. So it's a huge problem, especially in sports. And it's amazing how few people have actually done just intervention studies, RCTs. I think there is one RCT almost in this cohort. So it's really, really understudied on a huge problem. I'm sure you see these kids as well. And the normal advice they get from the GP is to rest and to wait, because it would always, not always, but they always say this is a self-limiting disease and will go away by itself. I can tell you from our data also on this, we followed them 2 years now already, that 1/5 after 2 years will not be back to sport. So the fact, you can't say that this is a self-limiting disease. For some people, this will be the end of the sport they're doing. Okay, so this was the intervention. We had 51 here, and this was the study I just showed you with the deficits. And again, this was what we found. Let's skip that. The current recommendation very often is rest and stretching, and we thought that's probably not going to help somebody who has a big deficit and who's being very physically active. So why should stretching work on them if they just keep being very, very active? So this was the main idea, was to try to change this paradigm a little bit and see if you could do something else. So the idea was to look at knee strengthening, or actually sort of loading, and then also to have a tool to guide the return to sport. So this was the main idea of this trial. And this was an intervention study, there was no control group, but I'll show you a little bit of how everything was designed. It's two-center study, two centers because it was mainly for the PFP study, but we also had these 50 patients in this. I'll talk about the PFP later, that followed a very similar approach. Okay, so this was the assessment for inclusion, and this was all the times that we would see the patients. And here they would see a physio. And here we would just be following them up. So basically 5 times, 30 minutes, nothing more than that. But they had education, and they were also educated on the training they had to do themselves. And this was how we measured the success. We used much better or better as an indicator for success, and then this was not successful. We can discuss whether this is a good way to do it. We did that because this is the way they usually do it in this kind of research. We wanted to compare with the rest of the research out there. And so the main idea of this was to give them some education. So I had this folder. So I tried to empower, explain to them how, so they came in with their parents, which was a very important thing as well, and we tried to explain how they should now decrease their physical activity for 4 weeks, and also how they should sort of manage that. And one of the tools I'll show you in a minute, I think Roland will be very happy about that tool we used, was something that has been developed here in Göteborg. So this was, I would say, the Roland to make pain scale, and they were told we don't want pain above 2, so you can do activities where you have 0, 1, and 2. And then the other thing was they had a block here where they did some very, you can say not very high activity exercise, just pelvic lift and also just activating your quads. And then these kind of activities, so walking, cycling, stuff like that. Nothing that would really aggravate your musculoskeletal. And then the idea was just to progressively reach the next stage where you could do this painful, then you just go to a higher stage. Now you're isometrically activating your quads. You're allowed to walk a little bit more, cycle a little bit more, and then all the way up here, then you start to do things on one leg, and you're also allowed to do something that is more vigorous. So basically, just educating on them on how they should progress, and they got this folder with them back home as well. And then they would be followed up with the days and the weeks that I showed you. So a tool related to activity, to exercises, and to how to manage pain during exercises, and also in their daily life. And these are the results. So we had these 51 adolescents, and you can see 74% were sports active, and you can see that 49 had reduced their sports participation because of their knee pain, and again, had symptoms for a long time, and worst pain was here. So this was the baseline, and if you look at the success rate, again remember, if you get to improved or much improved, it will be defined as a success. And here, at 4 weeks, only 40% were at a level where you would say it was a success. At 8 weeks, it started to look a lot better, and then you still had improvements up to 12 months, which is very important with this group, because they actually took a long time for some of them to get up to good standards. And you can see here 16% was back playing sport after 3 months. So again, just saying that, I mean, you have to, the expectations of being back in the sport that you were shouldn't be too high already at 3 months. That will take a lot longer for some of them, and not all of them will reach that level. 64% at 6 months, and then 70 or almost 70% at 12 months. So we don't have much to compare with here, but still quite a positive thing though that they are getting better, and you can always say that's just time alone, but this is not a very expensive intervention to do, and it's something that physios we could do and do really easy. So I would say it's probably the best available evidence out there, but you could of course always argue that this will also be relieved in other ways. 71% was satisfied with the result, and 96% would recommend the same treatment to a friend with knee pain. And we got the parents with us all the time, so the parents was there, and also to reinforce and help the children doing it, but the main idea was actually to teach the kids how to react and do it themselves. And this is the one where we discuss how successful is this program actually. You can say at 6 months you still have around half who consider themselves pain-free, so the other half doesn't, and this is actually at 12 months. So again, this is probably more management than completely free of pain treatment afterwards, but still something to give them. So seems that load management combined with progressive knee strengthening has a role, and we would recommend, and they're definitely happy to do it. And I think the most resistance we had was not from children, it was from their parents when they heard that the first 4 weeks they were not allowed to do their sport. So if you're playing football, you need for 4 weeks to stop doing that. And some parents would, on behalf of their children, say, that's not going to happen. And the only thing we could say then was, well, then you can't be in the program. So imagine you're a parent who, on behalf of their children, don't want them to be out for 4 weeks. And it's not that they can't be physically active, and we know it's hard, we all want to play football, but I think this was very, very important part of the treatment also when you consider how active these kids are. So this is all the people Michael worked with. If you ever get to hear Michael talk on these topics, please go. He's a fantastic researcher, and you'll hear much more of him in the future. Thank you very much.
Thank you, Christian. Next up on stage is Professor Mats Bygberg, who will be talking about the challenge of patients with cartilage injury. And if I understood Mats correctly, you would like to have, if you have any questions, they may ask them directly. He would like to interact with you all throughout the presentation. So please, this is a great opportunity, so please ask questions.
Okay, first of all, I must thank you for inviting me to this meeting, and I've been given the task to talk about what is new about chondral injuries and what to do. So you could talk a lot about cartilage and how to manage cartilage, but the presentation today is more focused on what I'm using for cartilage repair and what my fellow cartilage repair surgeons are using for repair. When I arrived here, you talked about osteoarthritis, and I think this is what I want, what you should know about cartilage injuries, that there are 3 types of cartilage injuries that we could treat. We have the pure traumatic cartilage lesions that we normally work on because we think they are painful, so we could do a cartilage repair to plug in the defects to get an even surface again. But in between the traumatic defect and the osteoarthritis, we have what I think is important to differ. It's degenerative lesion, because a degenerative lesion could be osteoarthritis, but most often it is not osteoarthritis. And that's important because many patients has heard that they have developed osteoarthritis, but when the patient comes to me, I say, well, you don't have osteoarthritis, this is a degenerative lesion. And degeneration just means pathological cartilage. After a meniscal loss, after an ACL injury, you could have trauma because of instability, and you induce pathological changes of the cartilage, but still it's not osteoarthritis. Osteoarthritis could be localized defects. It could be lesions that are stationary, or they could be lesions that are progressive. And when you remember that, you could see the difference also between an osteoarthritic lesion and a traumatic lesion and a degenerative lesion, because the traumatic lesion is normally found in a normal joint. A degenerative lesion early on could also be found in a normal joint, but osteoarthritic lesions, they are in an unhealthy joint. It's an organ disease, so the whole joint is diseased, which is the differences. And when I'm doing cartilage repair, I'm focusing on the left side, where I do repair on traumatic defects and on degenerative lesions, but normally I'm not treating osteoarthritic lesion with local cartilage repair. When you look upon treatment today of cartilage, most of the technologies that are available are based on producing a cartilage repair by inducing a blood clot in the defect area. And with the blood clot you could attract cells from the bone marrow to migrate into the blood clot. And if you look upon the blood clot, you will see that the blood clot looks like a matrix, so the cells could climb in the blood clot. And the blood clot also contains growth factor stimulation, so they attract the cells from the bone marrow to invade it. The most common, many years ago, way to treat cartilage defects were to do drilling, and we call it Preedy drilling because it was developed by a Scottish surgeon, Kenneth Preedy. And today we could say that's a revival of the drilling technology, because it was lost for many years, because instead most people were using microfracturing. Microfracturing was developed by Dick Stedman in Vail, Colorado, and influenced all over the world because it's a technology that is very simple to use for cartilage defects. You could use different awls that are curved, so you could reach different areas of the joint, but you go very shallow into the bone. You try to reach vessels that are in the cortex, so you do only 2 to 3 millimeters down into the bone, so it's shallow lesions, because Stedman thought it was important to preserve the subchondral bone. And Stedman also influenced that you were not allowed to bear any weight on the joint, or very little weight, which has influenced all cartilage repair during many years, which I think have been little negative, because it's important to bear weight when you have treated cartilage defects. But during the years we have seen, when you do this microfracturing, it is like the word fracture, because you induce fractures in the subchondral bone area, which means that the cells, they will have difficulty to enter to the joint because they have to go around the fractures, so that could be a negative thing. And also with this bone marrow stimulation, you induce also an overgrowth of the subchondral bone, so the patients are doing quite well from start, but suddenly they start to have pain. And if you do an MRI, you don't see anything. If you do an arthroscopy, you see a nice smooth surface. So if you suspect a bone ingrowth, you have to do a CT scan, because the CT scan could notice how the bone is growing into the defect. So it's like a little mounting into the defect. And when you looked upon it with the arthroscopy, it looks smooth, but when you scrape away the repair tissue, you will see how the bone has protruded into the defect, and by time it destroys the tissue. So this was interesting when the reports came with these bone ingrowths, that in a meeting in 2009 in Canada, they presented a study where they looked upon rabbits that have been operated on with microfracturing, with shallow bone drilling, and with deep bone drilling. And with the deep drilling, they got significantly better repair tissue, a much stronger repair tissue compared to shallow drilling and microfracturing. So we discussed it during the coffee break after their presentation, and we said that this is a very nice study. We think it will have an influences on the repair in the future, and quite fast industry follow, and they developed what they called nano. Nano, you know, is very thin, very small, so they introduce nano drilling. That means that you should go deeper down into the bone. Instead of doing microfracturing, you go like 7 to 9 to 10 to 12 millimeters into the bone. And when you go so deep, you will reach the large vessels, and on the vessels, pericytes, which are stem cells, are growing. So these cells are attracted and could go into the injured area and treat it with a stronger repair tissue. And they also developed very thin instruments, so you could use it. And when you have very thin instrument, instead of pushing down fractures of bone, which will have problems with the cells, the thin opens up areas. You see the yellow notes there, where the cells could walk into the channel and then be introduced. And you see on the picture here the difference between microfracturing, which reaches smaller vessels. Here you go deeper down, so-called nano deeping. And sometimes it's words power or thinking, you know. The instruments are not nano instruments, nano is extremely small, but the word is quite powerful, so patients could be treated with the new technology, and the doctors are attracted to buy the new instruments. So you could say, when you compare today as an orthopedic surgeon to treat cartilage defects, should I do microfracturing or should I drill? Well, deep is better than shallow, small is better than large regarding the size of the instrumentation, and thin needling or drilling is better than microfracturing. And today they have also developed instruments that are flexible drills, so you could drill in areas that are difficult to reach, like into the ankle joint. But most often these microfracturing or bone marrow stimulation are good for small defects. Some defects are a little larger, then you want to improve the repair, you could augment it. And there are many methods out there that you could use for augmentation. One of my favorites that is very little known, because very few people have used it, is carbon fibers. And carbon fibers are started to use in 1988. You drill holes 12.5 millimeters down into the bone, and you put carbon fibers, that is polyester, that have been heated to more than 1,000 degrees to induce a meshwork of carbon filaments that could be woven into a meshwork, and you put it into the bone. And what was interesting is that I noticed that you have a very strong repair tissue and pain relief, and actually those carbon rods are put very deep into the bone. So the way that they describe in the animal experiments and has now been developed into nano drilling was maybe also the explanation why the carbon fibers has been successful in treating the patient's pain. However, you could also use other types of augmentation of the repair tissue, and many of them are based on different types of synthetic material that are woven in different fashions. So you have one phase that is for the bone and one phase for the cartilage. So these type of implants are very good to treat osteochondral defects. And many defects are deeper than just to the bone plate. They often go through the bone plate into the bone. And here is one of these implants that is used quite a lot of in Europe. It's a collagen made out of horse tail, and it consists of two phases, one for the bone and one for the cartilage, and you put it into the bone here. And they have done a randomized study in Europe to show that with this type of implants you had significantly better effect compared to microfracturing if you treated deep osteochondral lesion, and interestingly also in sport active persons, because you get a very strong durable tissue that could stand for wear in sports. you could see this type of implant that you could size and put into the defect, and then it swells, so there's no special fixation. There are also other types of materials of synthetic origin. This is made out of coral, red coral, and they have also a bone face and a cartilage face here. But common for all these type of implants is that there is very slow bone repair. And for example, the myoregion that I showed has quite a slow bone repair. And that is interesting because in Denmark they noticed a very poor bone repair, so they were much concerned about it, and they withdraw the implant from the market. But their patients did very well, and actually it could be like that instead of having a very fast bone repair, which means that you will have a very stiff bone, which could be painful for the patient, because when you have bone repair, also vessels grow there, and with the vessels are the nerves. So I think it may be that you should think vice versa, that instead with the slow bone repair, you will have less pain, and by that a better situation. You may have heard about an implant with the name of VI TrueFit. It's a little similar like that. They also had poor bone repair, and the company withdrew it for the market, but also there, with their implants, the results were very good for the patients. So I think in order not to be too hasty, you have to look upon the situation, and especially what we are treating. We are not treating the patient's images, we are treating the patient's symptoms. Here is another way to treat the cartilage lesion, is to cover the blood clot, to protect the blood clot. And here they also put a very nice name on it, AMID, autologous matrix-induced chondrogenesis. It's much used in Germany and in UK, and you could cover it with a collagen membrane or hyaluronic acid matrix, different type of cover to protect the blood clot. They made a randomized study in Germany, but they couldn't see any differences clinically between with the matrix or just with microfracturing, but it's widely used nowadays. Here is an interesting alternative to improve the repair, is to make a better blood clot. As I said, the blood clot is the ground of how to repair cartilage defects, but if you could induce a super clot, a very strong blood clot, then you will have a better repair. And they developed a blood clot by mixing the patient's venous blood with chitosan. Chitosan is the second most common polymer in nature, and it's made out of shrimp shells. And you know, there are so many different types of insects and animals that have shrimp, the shells. So this is the chitosan from shrimps that is used, and make a very strong blood clot. And they did a very nice study, a randomized study, to show that at 2 years follow-up, they had significantly better MRI and histology compared to microfracturing. So this is widely used, and even here in Sweden, but quite expensive. This is also an interesting implant. I'm just started to take part in a randomized study. It's a gel, polyvinyl alcohol gel and fibrin, and it's put into the joint, into the defect by injection, and then you put ultraviolet light on it, and with the light you stabilize. So it's as a gel, it's very good, and the company has now also developed a paste, and paste is what I'm been looking for, because then you could inject it and you could form it exactly so that it fills out all this area of the lesion. So this is something that we will see in the future, and this is an interesting one. And if someone has a patient with a cartilage lesion, you could send it to me, because we need patients to be part of this study. Some of you have also been involved in these types of repair. Perichondrium was popular in the 90s, but almost no one is using perichondrium anymore, because they produced calcification of the graft, and the graft loosening, but in young patient perichondrial resurface it could still be good. The same with periosteum. Periosteum was also very popular in the 90s, but almost no one is using anymore. But I still think in an acute situation, a patient come in after a traffic accident and have a lot of injuries and you need to treat also the cartilage, then you could use periosteum directly for those patients because periosteum could produce nice cartilages repair. Mosaic plaster plugs were also popular in the 90s, and it's also gone down, maybe because if you want to treat larger defects, it's technically demanding, and you're also stealing cartilage and bone from areas that normally should be non-weight bearing, but if you need to treat a large defects, it's difficult. But I think this is still an option for athletes when they want to go back quite fast to sport, because you have an immediate cartilage repair tissue that needs just bone repair, and it's even faster than microfracturing. So this is a solution still valid. Well, allograft is something that is very good to use for very large defect in young patients. The problem is that you have lack of donors and you still have the risk of disease transmission. It takes around 6 weeks until if you take a blood sample to see if the patient will turn into HIV positive. So it's a little risky with this type of allograft, but if you look upon the big materials that are in the US, they have had little problems with that. And I also had a communication with a group in Mexico City that are doing a lot of allograft, and they test it and they have very little problem with it. Around 50% of the patients develop antibodies, so some reactions you could see, especially if you have a large portion of the bone. So it's better to have a very thin portion of the bone to have less allergenic reaction. I think we will see more of it in Sweden, because it's something that we should have, at least at 1 or 2 centers in Sweden, should be able in the future for large defects offer the patient the possibility to have an allograft. And you know, you could also have the combination of the condyles with the meniscus. So if you have a very large defect in a tumor resection in a young patient, these are important part of the repair tissue. Exists also as decellularized allograft, which is good because you could take it just off the shelf and put it into the patients. But the recently published were not so good, so I'm not sure that this will be the solution because they are quite brittle. Then you have cells, and you know, here in Gothenburg we did the first chondrocyte transplantation in the world in October 1987, so it's 31 years since we did the first operation. And since then, there have been several of different type of generation. The first generation is with the cells in suspension with periosteum. The second is with a collagen membrane and suspension cells. Here you have third generation with cells grown on a matrix. And here in a matrix, and then fourth generation of ICI with different types of alternatives. With the first generation of ICI, there are several long-term follow-up up to 20 years that the patients are still doing good. But very few are using the first generation today. Nowadays it's the third generation with cells in the matrix where you could do transplantation arthroscopic. Many patients today, even in Sweden, say that chondrocyte implantation technique is experimental. But you know, it's a technology that has been there for more than 30 years. There are 18 randomized studies with ICI versus different types of technologies. I think that's important to remember that this is quite well-studied technology, and it has been studied versus microfracturing in 8 of these studies, and 6 of 8 had significantly better result versus microfracturing. So I think it's quite well studied procedure. The most recent study is the MACE study, where cells are grown on a material and are implanted into the defect, where the cells walk off the membrane. It's like a cab bringing the patients into the defect area. And this is the largest cartilage repair study so far, with 144 patients. And in this study, we could show that the cell transplantation was significantly better than the microfracture in Coos pain and function at 2 years, at 3 years, and at 5 years follow-up. So it seems to be durable. The fourth generation of ICIs that we will see more of is that you isolate cells directly in the OR, because today you have to send away cells and it takes 2 to 5 weeks before you get them back. Here you could isolate the cells directly, and here there are 2 different studies going on in Europe where you mix the cells with stem cells, either from the patient's own stem cell from the iliac crest or allograft stem cells. So maybe we will see something of that in the future. However, this technology is cheap and easy to use. It's the cartilage fragment technology, and I think this is something that we will see more of, because here you just take small cartilage fragment. You could take it from the cartilage lesion, from the surrounding, and then you smash it into small pieces and put them then on a membrane and put it into the defect with glue. And from the fragment, the cells could migrate out and start to produce cartilage tissue. And they have had 2 studies, one in Europe and one in America, and both studies showed the same, that you had significantly better result with the fragments. And you could see here, in this picture, the blue is the fragment, and the pink is from the fragment cells that have migrated out and started to produce cartilage. So this is quite interesting. It's from my colleague Sebastian Concara, who is working also in Kungsbacka. He made that in his thesis. So it is possible, and this is quite simple because you don't need any culture technology, and you could do it directly at the time of surgery. So this is something that we will see more of. And as an alternative, this type of fragment could also be used as allograft, and they are taken from young juvenile cartilage donation and are used in the US. There is a lot of patients treated with this technology, but up till now very little results. However, in order to have a very strong and improved repair tissue, you could do something else. You could give an injection of a growth factor that stimulates the bone marrow, so the bone marrow releases so-called stem cells into the blood, and those stem cells are called peripheral blood progenitor cells. And those cells are then injected into the joint where you have done bone marrow stimulation like microfracturing. And with this type of injection, you stimulate the cells to produce a better quality of repair tissue. So this is interesting, something that we will see more of also in the future, but very few have done repeated studies of this technology, but it's interesting. They did a randomized study, small study, and could show that they got significantly better histology and MRI with these type of injections, but they couldn't show any differences clinically. However, as you have said, certainly have had patients today that get another type of growth factor stimulation, and it's PRP, platelet-rich plasma. And it has spread, so it's a lot of treatment today, but the drawbacks with these type of injections makes it very difficult to compare from patient to patient, because if you take a sample from me, it's a variation of my thrombocytes from day to day, from hour to hour, and from patient to patient. So how to compare? And the results that are out there are very controversial. At the Academy meeting this year, I had a meeting called Use and Misuse of Biologics, and they went through this because, especially PRP, they say that PRP does have a promise, but further refinement is required. So there are still not so many convincing studies, and especially as there are individual variation from patient to patient. Similarities with the stem cells. We have not seen so much of it in Sweden yet, but in Europe, patient could go, and even Swedish patients, they read in the internet, and they want to go to have injection. One patient went to Spain, one went to Poland, and one patient was promised the stem cells injection somewhere in Florida. But you know, the most used stem cells are not from the bone marrow, or it's all from fat tissue, where you take fat from the belly and smash it into small pieces where the cells could be released, and you could have that to be injected into the joint, especially for osteoarthritis. But also here at the academy meeting, they said that while there may be promise in certain cell-based therapies, currently do not have evidence to tell our patient that they can expect good outcomes or avoid surgery. So even here you have to wait, and some patients, they go with an overweight body for fat aspiration to be injected into the osteoarthritic knee, when they instead should have reduced their weight. So that's words power of thinking. Stem cells is a very strong word. However, biological treatments could be good in many occasions for local cartilage repair, but they are responders and non-responders for all techniques. And one new technology that is interesting to use is mini metal implants, MMA, the MMA of orthopedics, where you from a three-dimensional picture could produce an exact copy of the cartilage lesion and then implant it. But the indications are for those patients that have failed one or two biological repairs, then you could use it, because if you will fail the metal implant, then you have to be prepared what to do, because then you will have a large defect area to replace. But I think this is also an important part in the toolbox as an alternative treatment. Finally, regarding cartilage repair, this is something that is started to be more interesting treatment all over the world. It's unloading, because when you have a small defects and have a malalignment, it might be no problem. But if you have a malalignment and a large defect, the repair tissue will be poor, and you will have problems with the development of the repair tissue. So if you could unload it temporarily with an unloader brace, or if you could unload it with osteotomies. And osteotomy is the #1 favorite operation among cartilage repair surgeons like me, because finally, after doing several cartilage repair, patient is still in pain, you do an osteotomy, and after a year, patient is happy. So this is a very good operation, you should remember. But it's a large operation, and for some patients, quite tough. However, you talked about osteoarthritis earlier on, and we don't know which are the lesions that will progress from the small one to a larger one, and finally to osteoarthritis. It's a combination of a lot of things, as we said, that the patient's weight and the patient's alignment and patient's ability to train to improve the joint homeostasis, which is very important for the joint to function. But finally it could turn out that way. And for us as orthopedic surgeons, we have to find them early on here and try to, at least when they go into this area which is called pre-osteoarthritis, to push them back. And that is what is very important for the physiotherapist also to this area, to get patient. Maybe we could push them back from going down the hill also here, but we don't know where. Maybe an osteotomy could help them to stop the process to go further on here. So this is an important schedule to remember. Finally, for me, I have a simple algorithm when I'm treating cartilage defects. If you have small defects smaller than 1 square centimeter, you can go for bone marrow stimulation. While the larger 1 to 3 square centimeter, maybe you need to put such a matrix like an augmentation to improve the repair tissue. If you have very large defects, which is more than 3 square centimeters, you could use cell therapies that are like chondrocyte transplantation, which are quite expensive. This cell therapies could also be used for smaller defects if you do reoperations, and that's what I'm doing mostly, so being what I call myself a second-hand surgeon. Allograft you could use for extra large defects, and I think we need to have the opportunity in the future to offer the patients allograft not only for cartilage but also for ligaments as we do already today, but also very important for the meniscus. And don't forget that unloading osteotomy are useful in combination with local repairs. So thank you very much for your attention.
Thank you, Mats, for a great breakdown on the broad area of cartilage injuries. As you all understand, Mats has very much experience and has been a pioneer in this area. But we'll keep on going through this symposium. So Roland's going to give you a little challenging comment about what has actually happened since 1995 when he defended his thesis on patellofemoral pain. And then maybe Christian will respond. Maybe.
Thanks, sir. Tack så mycket. Patellofemoral pain is a problem during ACL rehabilitation. It's a problem on its own, but with patients that have ACL injury, it is a major problem. And what can we do? First, if you look at the knee, it's an amazing structure. There's so many details, and we all look different too. A lot of forces pulling in various directions. So it is, by looking at this, it has to be complicated. I'm not sure if we built the knee today that it will look like this, but now it does. And it's surrounded by muscles and tendons and ligaments and the joint capsule and various structures. And as usual, it's very important with big muscles. Again, this picture is a couple of years ago, and I used to be in the weight room a lot. Then the knee and the body is controlled with motor control. The muscles, the regulator, there are sensors, and it's a very complicated structure. With this in background, I approached my thesis topic in the early 90s and presented a thesis in 95. And I had a super team of supervisors, and we looked at patellofemoral pain syndrome in young women. We did studies on alignment, check if they were valgus, varus, or whatever fault with them. We did pain assessment, an assessment of muscle function, and we had a model for treatment, evaluated in a randomized controlled trial. Now the patient presents with symptoms from various situations, which makes it frustrating. Walking up and down stairs, squatting, being physically active, running around, but also pain while sitting. How many of you have experienced pain in your anterior knee while sitting? Hand up. So you have patellofemoral pain. Or you have anterior knee pain. And that makes it really frustrating. I have pain in all different situations, the patient says. And then there's been a debate, and there still is a debate, shall we call it patellofemoral pain or anterior knee pain, which probably is more correct. Anterior knee pain, you can have anterior knee pain for a lot of reasons. But if you make a careful diagnosis of your patients, you often can't find anything wrong that might explain it. Maybe you're not looking carefully enough, but there is a fairly large group that we say, okay, you have a patellofemoral pain syndrome. You have various symptoms. You have pain, you have swelling, you have whatever stiffness, there's crepitations, and you have this syndrome. And still, I don't know if anyone can explain where the pain is coming from. I don't know if Christian or Mads, if we have moved any further. In the 90s, we said we don't actually know where the pain comes from, because the cartilage doesn't have any pain receptors. The subchondral bone has. Is the pain caused by increased pressure? Is there something wrong with the patella pressing on femur? Is there microscopic tissue damage that we can't see but can generate pain? And does it come from other capsular structures? And sometimes it does, and it's a syndrome, and it differs in the various patients. So in the literature, we've been discussing contributing factors. Malalignment is one, and we discussed the Baton score. Are those more prone? Is it if you have a flat foot and you have knees like this, are you prone to have patellofemoral pain? So there's been a lot of surgeries performed, correcting, straighten up your knees. And many of those surgeries are not performed that much anymore, because the success rate is low. Could there be a muscular imbalance? You're too weak, or you have one weak leg and you're running around, and you're overusing the one knee. So if you can find muscular imbalance, there's an exercise program that we can treat you. Overactivity says, you're running around too much. No wonder you overuse something. But why do I overuse my knees and my friends are overuse their shins or their hips? Well, we're all different. Some people, we don't know really which acquire patellofemoral pain or anterior knee pain from overactivity. So we need the activity protocol, and the one approach you suggested is very good. It's promising, Christian. And if we can't find anything here, we say that there's something wrong with the patient, psychological aspects. And that's where we got into our interest in studying self-efficacy. It sprang out of this. But I'm not sure it's a big factor anymore, because, and if it is, we have coping strategies and we have strategies for that. But I think it's a long-term, long-standing, many goes for many years with pain on and off in their knees. Does that make your psychological profile change? Yes, it does for all of us. But I've seen a lot of patients where we successfully reduced their pain, we took it away, and suddenly they became normal again. The psychology, so if you're prone with some personality or not, I'm not sure. I don't think that's an important factor, but we have to deal with it. Again, there's a discussion of muscle function, closed and open chain, compression forces, the vastus medialis, you have to exercise that. It has not been shown that you have to do that, but it's been suggested. And this is the ultimate question that we don't know how to answer yet. Are deficits in muscle function that you see, is that a cause of the symptoms? Or is that a symptom of some overuse in the knee? Well, we don't know. And then we have overactivity. And in the 80s and the 90s, there came studies out that suggested that it appears that the stimulus for developing and exhibiting patellofemoral pain may be related to increased physical activity. And we did a study, it's not published, it's a Bachelor of Science project. We looked at close to 1,000 youngsters, and we saw, yes, the ones that are very active have a higher prevalence than the ones that are not active. So our suggestion to the school was why don't you stop that sports education program you have? Don't have the students run around and you will save their knees. No, we did not say that. You have to realize that the knee, as many parts of the body, are exhibited to large forces. If you jump like that, and you can try, stand up and jump like that. Please go ahead, you need to move. Stand up, go like this, jump up and land like this. Just to be careful with your knees. Okay, that's good. You're done. If you do that and you land stiff in 90 degrees, and of course you don't do that because you break yourself down. But if you fall off here, you can be in that position. Suddenly you have to break a lot of force. And it can be tremendous forces. The compression, the shearing, the torsion can be tremendously. And of course, that can injure your cartilage. And that, if you want to get back to sports, you have to increase the tolerance in the knee, and that will take time. We made a kind of diagram that we thought this somewhere here is in the explanation to explain patellofemoral pain. There is some overactivity. Maybe malalignment is part of there, or other background factors. But if you get pain, you reduce your activity, the muscles get weakened, and muscle wasting, increasing the muscular balance. You continue to exercise with this imbalance, and you're in a bad circle. But as always, exercise is the medicine. But does cartilage or the knee joint respond to exercise? Yes, if you look in the literature, they said back then, and it's about the same, you can say today. Experimental studies show that if you perform regularly, repeated over a long time, slowly progressing, increase in small steps, non-strenuous physical training, you start on a low level, on the cartilage level, or whatever level the knee can withstand, you will cause meaningful adaptive changes in the articular cartilage, or in the knee. And you've seen patients that have patellofemoral pain, cartilage problems, you take them on a long journey, and they improve. But if you take an x-ray before and after, you probably can't see any difference in the knee. Maybe sometimes, but maybe not much. But patients can have cartilage damage, osteoarthritis, or problem with the knee, but there's very difficult to find correlation between how your knee look and the symptom they exhibit. And we can explain that it's possible that moving the knee joint, you get a diffusion of joint fluid, you press the nutrition into the cartilage, you can get, by time, an increased thickness, decreased friction, increased load tolerance. And this is important. If you do the right exercises for a long period of time, you can increase load tolerance in the knee. If you look in the literature, the systematics reviews are not that many. There are some I present here. This is in 2001, main message. The evidence is limited and further studies are needed, okay? In 2003, same message. Given the limited number of high-quality clinical trials, recommendations about supporting or refuting treatment approaches may be premature and can only be made with caution. Some promising. This is a systematic review from 2017. Conclusion, when they looked at all these studies, exercise prescriptions in randomized controlled trials with proven efficacy for patellofemoral pain are poorly reported, impairing their implementation in clinical practice. And in our randomized controlled trial, we had compared the group that had an eccentric program, because that was popular. Eccentric movements treats everything, compared to more traditional isometric. I think it was, I can't remember anymore, but I think it was for 3 months, and all the 40 patients improved, but we couldn't see any significant difference between the groups. So we don't know if it was eccentric or isometric, but it was probably the whole package. First of all, they had me as their physio. That must have been something. And then I told them, I gave them promising hopes that this is going to be okay. And I had them exercise for 3 months, and they improved a lot. So it's possible to treat these patients. And here is your friend Michael. And now you're promising some future good results, Christian. Let's hear what you have to say. And before I just say what I think we can do about the patellofemoral thing. We can continue to improve ACL rehabilitation. We should strengthen self-efficacy, restore range of motion, which I think is very important, and try to improve muscle function and motor control, and increase our knowledge about patellofemoral pain. And Christian, you will try to increase our knowledge. Thank you.
Thank you very much, and thank you, Roland. And I think it's great that I can go a little bit full circle on what Roland started many years ago. So, because a lot of what we do is inspired by his early work on this, so this is fantastic for me. Again, this is Michael's work. Please don't treat the results, but other than that, you're fine. So we actually do quite a lot of qualitative data on these patients as well, and this is just one of the quotes that you can say for this from Christina, 12 years of age. I hate my knee pain, but I love playing football. And this is the dilemma that these people have a lot of knee pain, but they still also love their sports so much that they keep going. Another way of visualizing what Roland just said is trying to see if we can match load, probably mostly training load or general daily load of the knee, to the capacity to actually handle that load. And this would be a situation that we do not want on any tissue in the long run. Basically what we want is try to have a training load that is balanced by the capacity to handle that load. And that certainly goes to cartilage as well. The other thing that I've said once before is that these patients are not characterized, these again the young patients, the 10 to 14-year-olds, are not characterized by large strength deficits as adults. So we shouldn't treat them as we treat adults. And you remember this one, I'm surprised that these people have this for a long time. And I think what Roland also said, and what is really important, the best predictor for a poor outcome is actually how long you have your anterior knee pain for. So the longer you've had it, the worse your prognosis. And this is also why we thought that we had to change the paradigm, because we need to get to these patients a lot earlier. And this was the whole idea of this. And even when we try to get as early as possible, we're still late. So what you will see is that this was actually the main study we did. And the first study I talked to you about was basically just a spin-off from that study. So this was the study that Michael got all his money for. And you can see here that they were diagnosed like we usually do during different activities. It's a diagnosis by exclusion, I agree. And we had MRI also to exclude anything serious on the meniscus, on the cartilage in this trial, and other concomitant injuries. Look completely the same as with the Oscar-Slatter. So this was actually, we modeled the other program around this, but there are some differences, and you can see it's also a much larger study. So 150 of these young participants, and it's not difficult to be the largest study because there's not any studies almost here, but this is actually a very large study compared to what you usually see in patellofemoral pain as well. And this is an important time point. Here we did the assessment also in relation to physical activity. and here we did it again. And what we saw here was that when we told them to decrease their activity, they did so. Probably 2 hours a week on the vigorous part. It means that they're still doing a lot of vigorous, and we don't know exactly what kind they took away, because this was just activity at a certain level. So it would be interesting to see if you get those peak loads out. That's what we're expecting, because that would usually be the one that are painful, and that's also what the program says, take out the painful activities that you do. And we did the same with the oscillosladder, and we also validated again in the end of the 4 weeks, and it was around the same, 2 hours during the whole week we could take out vigorous activity. So they are responding in some ways to when we tell them, please reduce your activity levels. Again, we use the same outcome here, and we also have the course. I'm not sure I have the course data, but I'll tell you about it. So here is the activity modification in week 0 to 4. The exercises are very simple here, double limb bridge and static holds for the quadriceps. So we don't go very hard on the actual knee joint structures. And here they get the activity ladder. So here we tell them, here they are not allowed to do much activity. We take them out of the sport. And here we tell them how to get back into the sport. And they use the ladder, and they use this 0 to 10 that Roland has developed and is the father of. And we also gave them more strenuous exercises, not with the intent of making them stronger, but again also a part of loading them up and also making them used to load their knee and their hip. And here we include a return to sport with 6 steps, also with the ladder, and a graded return to sport. So again, this is not rocket science, and I'm sure many of you do this already. But I think the main thing here is that sometimes when we do this, we tell the patients this, or we tell it to the parents, but we don't have a formalized, standardized folder, and we don't stay on that topic and say, this is what you have to do, this is what you have to do, this is what you have to do. So that's probably what we really emphasize in this study. Then there was some education on why do I get it, what's the risk, and just trying to educate them a little bit, and that also had different steps. So this was a 30 to 45-minute session every time they were there, and we also progressed their exercises. Everything was in the written folder as well, but 4 visits with the physiotherapist, it's not a lot. I mean, and this is also why I'm quite happy to say that you can maybe use this. And even the worst thing that can happen is that they get better, which they could maybe have done without, but this is not a very expensive treatment anyway, and it's certainly something that will give you structure to the treatment. The aim was the same. This was the folder. Quit means get rid of your knee pain in Danish. I don't know how to say that in Swedish. And this again, Roland's model. Here you have the activity ladder. Again, this is how you get back to sport. You have to be able to do this in this area first, then you go to here, then here, here. If you are here on the slow running, then you have to go back to here. So this is what we teach the parents and the kids. And these were the results. 91% were sports active when they came in, but half of them have reduced the sport activity. And then you see the duration, 1.5 years, and then painkillers. I don't know, I mean it kills me every time I see kids at that age having to have painkillers. Who tells them that? And then quite a lot of pain. Okay, so here are the results again. Looks very similar. And here you can see again that around 12 weeks, so a little bit faster here, you actually get a better result than with the oscillosladder. And again, we're not curing everyone, which I think is the main point as well. There are some here that didn't do well. It's a smaller proportion, and you need to think of what to do with those patients as well. But on a whole, in general, they did really, really well. And we looked at the core score as well, and they went around 40 to 50 on the core score, up in the area of 80 to 90. And that's very, very good on the core score. So they had dramatic increases in their core score. And again, 75% was back playing already after 3 months. Remember the Oscar group? Much less, 16% at this point. So again, just to also show you that these are very different. They come from, Oscar come from high demanding sports. They're often very, very specialized, and they have to perform at a very high level in relation to function and how they should use their knee. These probably are more heterogeneous in the sport they do, but they actually are back and being able much faster as well. So I think there's a much more positive message you can send them very quickly, that the aim is actually in 3 months to get back into the sport. And then here we're down to 7%, and again high satisfaction, and a lot would recommend this to a friend. So is that better than the rest? Because we don't have any control group, so you can just say, well, you were just along for the ride, or what the disease was taking, or the cure was just taken care of by itself. But here you see, this is how we have done previously in 15 to 9 years old. This is how well they did when you did success rate. So very, very small success rate with exercise and education alone, where you didn't have that physical activity component. And this is one we published this also. This was the same or closer to that age group, and it was the same. There was no physical activity, there was no education on how to monitor or individualize your symptoms to the program. So there's some indication that this might be gives us a better option. But again, we have to be careful when we compare studies like that. But this is anyway for us, and I think the next step, of course, is to do an RCT and try to maybe just compare this to usual care. And sports participation, 12 weeks, 6 months, 12 months, quite stable. So here, treatment focused on self-management, had good results overall, not perfect for everyone, but very, very positive, and the important thing is to implement it, and we need more qualitative work also to try and understand the adherence and the compliance. We do have measures on that, and on a whole they were very compliant to the program. So this was very positive. And I think one of the things that happened in this study, and that might also, maybe our results will be better than when you repeat it, they were really, really happy that we were taking care of them, and we also brought the parents in. And because this was, I would say, we were giving them, offering something that was not there. So normally these people would go out in private practice, and they would get very different approaches. They would see the doctor would say this will go away. It wouldn't go away, and then they would, then what? Then they had it for many years, and they get anxious about what it is. So maybe it's just because we were offering something in a structured way that wasn't there. And this is Michael's collaborators, and you will hear much more about Michael in the next 10 years. Thank you very much.
Thank you, Christian. We're going to work this a little bit different than what the schedule says. So we're going to come back. We're going to put the speakers on stage, and we're going to do an interactive workshop where you could ask questions, and we're going to challenge it a little bit. But before that, please grab some coffee, some candy, go to the bathroom, and we'll see each other back in 5 to 10 minutes, or something like that. Thank you.
Lite kaffe kan vara bra, det kan vi ta. Ja.